All right, so I'm going to present some analysis I did at the municipality level in Belgium for the spread of COVID-19. And I want to investigate three variables specifically, namely first the onset of the epidemic, meaning the first day or date of infections, the intensity of the epidemic, meaning the infection rate per 1,000 inhabitants, and also the growth of the epidemic over time, meaning in the first wave, being from end of March till the beginning of May. And I'm going to do that by looking at the level of the municipalities, for which we have 581 in Belgium. And I want to do that because using the municipality as the level of analysis, I can find the correlates of the socioeconomic and demographic correlates of the three variables that I'm looking for. And so I want to see how these three variables are correlated with socioeconomic and demographic variables in my country. I'm going to use data provided by Cienzano, which is the public health agency at the federal level responsible for public health. Yeah. And they, since the beginning of the epidemic, they've been providing daily updates of number of infections for all municipalities. The period under investigation is the first few weeks of the epidemic from March 1 till May 4th. Why May 4th? Because at that day, the testing policy for COVID-19 was until that day, it was a uniform testing policy in the entire country. And so the municipalities or doctors or other agencies could not decide to test X or Y person. No, everybody had to follow a uniform testing policy. So the infection rates is really you can have confidence in it because it's not different. There's no different testing policy over municipalities. Also, the rules of enforcement were the same for people who did not want to obey the lockdown across all municipalities. And so I'm going to complete those infection data with socioeconomic and demographic variables, which are provided by numerous government agencies, such as income data, migration data, and age structure data. Let me say a few more things about the relevance of the municipality for this kind of analysis. So on average, a Belgian municipality is really small, so you can drive with your car 5 to 10 kilometers, and then you're already in another municipality. And so the large part of life in Belgium occurs at this municipality level. So people bring their primary, secondary school children to schooling in their municipality, sports activities, social cultural associations, small administrative political entities. This is all at the municipality level. It's the core commune or municipality which centers a lot of the life choices and behavior in Belgium. And also there's some virological reasons. So a team around Professor Piet Maas from the Rega Institute has sequenced several hundred SARS-CoV-2 genomes in Belgium. And his spatially explicit phylogeographic analysis allows to track the dispersal velocity of several lineages of the virus. And the dispersal velocity of viral lineages was a little bit more than 5 kilometers just before the lockdown and 1.2 kilometers a day in the first few weeks of the lockdown. And so that shows you that the virus initially spreads within the municipality before it travels to other municipalities. Yeah. All right, so let me give a preview of my findings. So in March, COVID-19 spreads faster in larger, more densely populated, higher income municipalities with more elderly people and a larger share of the elderly population residing in care homes. Municipalities which were more exposed to migration, foreign travel for business, leisure, or family affairs were affected earlier on in the epidemic. Richer municipalities managed to slow down the epidemic in April, more compared to poorer ones. And income correlates with the infection rate, in particular in the Flemish region, whereas the share of foreign nationalities correlates with the infection rate, in particular in the Walloon region. Now I would like to go in detail in how I got to these findings, starting with the onset of the epidemic. I investigate the start of the epidemic at the municipality level. Cienzano publishes the exact figure of infection rates on a given day only, however, when this figure is larger than 5. And this is done for privacy reasons. It also published the cumulative number of infections every day. So in order to analyze the socioeconomic and demographic correlates, I first have to estimate the first day of the infection when that number was lower than 5. So for 581 municipalities, we have the exact date of the start of the epidemic, defined here at least 5 confirmed cases for 309 municipalities, of which 205 reached the threshold in March and 104 reached that threshold in April. For the remaining 272 municipalities, Cienciano published the accumulated number of contaminated cases on March 31. And so for these 272, I will have to impute the day of onset as the average day at a district level, which is 1 unit higher than the municipality level. When I do this, I get kind of this graph for the kernel density estimate for the start day of the epidemic. So the black line is based on the imputation of the average at the district level for unknown municipalities. And the red line is another method, which basically gives about the same result. So why I do this? I do this because it gives me the start day of the epidemic at the municipality level, which I can then correlate with other variables at that same level. Yeah? So from that density estimate, I derived that 4% of all municipalities had their onset before March 15. 70% of municipalities had their onset between March 15 and March 30, and 26% after March 30. So this allows me now to do the estimates. So I derive in the paper a large number of hypotheses that I want to bring to the data. It's in the interest of time, I'm not going to list them all. I also have the models in the paper, which I'm going to estimate. And from reported cases, from the very first reported cases in Belgium, we know that the virus came to the country because of business travel from Wuhan in China, and also from leisure and ski travel from northern Italy. So people, either Belgian people or foreign nationals who came to the country by visiting these 2 areas, they were the first to bring the virus to Belgium. So when I do these analysis, which the start day as my dependent variable, I do this. I perform this by OLS estimation. And in the interest of time, let's only look at the last column in R6. So my regressors are listed in blue in the table, and you can see, so the dependent variable is the number of days after March 6. So the larger the number of days, of course, the larger it took for the virus to get to your municipality. So larger municipalities has earlier onset. Higher density municipalities had also earlier onset. When the percentage of population in your municipality was above a high population, above 65, so the share of the population was high for the share above 65, you have earlier onset. If you have a lot of singleton households in the household, you have later onset. It tells you a bit about the social effects of this virus, how it spreads. So a lot of singleton households in the municipality would slow down the spread of the virus. Income per capita, you can see that richer households, richer communities, richer municipalities were struck earlier by the virus earlier in March, and this is also related to business travel and travel for ski holidays, which is usually done by richer people. Also, the percentage of people above 65 who stay in care homes has allows for an earlier spread of the municipalities. I'm also looking at the percentages of foreign nationals in municipalities, and a higher percentage of foreign nationals allows for a further, an earlier spread in the community. When we then look specifically at which nationalities are responsible for that, is in particular the Italian, high share of Italians in the municipality, and also high share of Chinese in the municipality that allow for earlier spread. I will then go to my second variable, which is the intensity variable, calculated as the number of infections per 1,000 inhabitants. So I do this on March 31st. Why on March 31st? Well, basically because then it's the first day when we have accumulated figures of the Cienciano data, and it's also right before what I would call the high point of the epidemic in Belgium, at least during the first wave. And the high point is defined as the number of contaminations when the number of contaminations is lower than the day before. So the March 31st is about 1 week or 10 days before that high point. So we had about 12,000 infections at that point. And what I do is I regress the infection rate on the same set of socio-demographic and economic variables as in the onset regression. Here you see it on the map. This is really an indication of the spread of the virus in the first wave in Belgium. There are clearly defined clusters. If I would show you the map in September, it's completely different. In September, the virus was everywhere. In March and April, the virus was really clustered. You had a very few municipalities were highly contaminated, and you also had municipalities where the infection rate was very low. This was a very different picture than what we have today. So this is on March 31st. I do this regression analysis also with the same variables that I said. And so in the interest of time, I'm also going to look at regression number 6, which is the last but one column. Here, of course, the contamination rate, the effects, you will have to see that the sign of the variables is now inverse. So population density or population above 65 now has a positive effect on the infection rate, because the higher the percentage of people, the higher the infection rate. By what I just showed before, the onset, it was this negative relationship. Now, singleton households, for example, have now a negative relationship. The more singleton households in your municipality, the lower the cumulative infection rate. And you'll see, you will find less variables that are statistically significant. For example, the share of Italians and the share of Chinese in your population is now not statistically significant anymore. So they seem to be significant at the onset, but when we look at the cumulative infection rate a few weeks later, we don't see that anymore. Yeah. Also importantly, I included the start day of the infection as my first regressor, obviously, because that is very important. The sooner or the earlier you had your infection, also the higher will be the cumulative figure a few weeks later. Yeah.
2 minutes.
2 minutes. Let me then go to the last variable, is the growth of the epidemic. So I estimate the growth of the epidemic over time, in particular the change at a weekly basis. And by the end of the lockdown, we had 50,000 infections in Belgium. So the correlation between the dependent and the lag dependent is very high, even after a few weeks. So inclusion of the lag dependent variable in the model explains, of course, a large part of the variation. And I'm going to look particularly at the effect of poverty and wealth. If you see, this is the red line are the richest municipalities in Belgium, the black line are the poorest one. As I said, the richest one were disadvantaged earlier on in the epidemic, but 5 weeks later, they managed to slow down the epidemic much better than poor communities. You also see that in a difference in difference analysis, where the richest communities have fared better over the course of the epidemic. And that statistically significant at the 5% level. You can compute then how many inhabitants were more infected in poor communities than in rich communities, which I calculate at about 1,000 over the course of the epidemic. I'm going to look also at the entire income distribution, and we see here in the red line is the black line is the infection rate. The red line is the growth rate of infections. So more infections when you had higher income, but the growth rate, the red line, the growth rate of that infection is slower. And you see the turning point is about around 20,000 euro per month. In a municipality, then you manage to slow down your epidemic, basically because people who are richer are more able to work at home, can shield themselves, do not have to show up at the workplace, and so are better, have their own garden, live also with fewer people in the house, have bigger houses. And so this also explains why they have less social contacts at that moment. I do that also in a regression analysis, so either in a log linear model or in a linear model. And in the interest of time, you can look at regressions 2, 3, and 4, where you see the same variables popping up as before, and specifically the population above 65, the income variable, which is a negative, and also the population above 65 in care homes. I do also that with an IV method for those who are interested, and I explain in the paper. So let me conclude. So I employed log and log linear models. The log linear one captured better the exponential growth of the infections. I include lagged variables as dependent variables to capture the variation better. I do that estimation that correlates the start of the epidemic well as correlates of the cumulative infection rate. And I also turn my attention to the evolution of the epidemic by analyzing the cumulative infection rate. I find the same pattern in the three variables. So income per capita, the share of elderly in the population, the share of elderly in home care, and the exposure of the municipality to foreign travel, business, and migration show up statistically significant in the analysis. Income particularly in the Flemish region and foreign nationalities in particular in the Walloon region. I leave it there. Thank you very much.